Please bless this presentation, bless the speaker, so that we all will be blessed by what we learn, and we will apply into our daily life. In Jesus' name, amen. It is my privilege to introduce to you our speaker this afternoon, Dr. Sunil Norangi and his wife, Pushpa. Pushpa, can you stand up so everyone know? She is also a pediatrician at Loma Linda Medical Hospital. We welcome both of you to our church today. Dr. Norangi was born and raised in India of SDA parents. His dad was a pastor. Dr. Norangi had an Adventist education from elementary school through college. He obtained his MD degree from the Christian Medical College at Vollmer, one of the prestigious institutions in India. After graduation, he has been a missionary doctor in many countries. He met his lovely wife in medical school, and they have been married for the last 40 years. They have 2 sons, Kevin and Derek. Both are doctors. Dr. Norangi is specialized in internal medicine and interventional cardiology. He is an associate professor of medicine, Division of Cardiology at Loma Linda University Medical School. He is a firm believer of the SDA health message. He is also an avid runner and have participated in at least 20 marathons. What an impressive curriculum. I don't want to waste any more time of your time. Dr. Norangi, the stage is yours. Thank you.
Is the mic on? Can you hear me? Great. Well, David, thank you very much for those very kind words. And I feel like it was a little overstated in some ways because I'm not all that was said, but it's a pleasure to be here this afternoon. And both my wife and I, this is our first visit out here in this church, a very lovely church. And we have been impressed with what we see and what we are seeing. So it's a great pleasure for us to be here, and I want to welcome all of you this afternoon. We'll spend a few moments to ponder on how we can take care of our health, and particularly learning a few things about the stroke and the basics of stroke and stroke prevention. So without much further ado, I just want to say that as I practice my art of medicine, when I walk around and ask the patients, when I come face to face and I say, what's your goal? What would you like to have in life other than good health? And it's not uncommon for us to go over things that are important for them. And I have heard it more than once that, Doc, I can have anything, but I don't want to have a stroke. Because the stroke is something that disables you so much. Can't walk, can't lift your arm, you're wheelchair bound. Next thing you know that you are in a nursing home. And it's never a pretty picture. It goes down and down and down. They would say, yeah, cancer, I don't like cancer, but if I have to take cancer, I'll take cancer. Or some other form of problems, but not stroke. So stroke is a very disabling problem. And what I'm going to review here this afternoon is nothing is new for you. You probably know it all. But let's spend a few moments so that it encourages all of us to be participant of having good health and maybe prevent having a stroke. And that's the goal for this afternoon. And if I left a message of some information or some piece of knowledge with you that will be beneficial for you in any little way or big way, it'll be a success on my part. And so it's a great pleasure to be here, and let's get going so that we'll get all the slides seen in a timely way. So thank you for having us over here, and it's a great pleasure to be here. All right. So what is a stroke? We can answer this, that a stroke is a damaged part of a brain because of the loss of blood flow or supply. So if the blood flow or supply to the heart is impaired and has been stopped for a certain period of time, then it causes the death of brain tissue. So you look at this brain here, and the pink part is the healthy part of the brain, but you see this yellow part or yellowish whitish part is the area where the brain has become necrotic or the tissues have died, and that's because the blood supply to the brain was compromised or stopped for a certain duration of time, resulting in the death of the brain tissue. So that's the stroke. The stroke, in other words, is the death of a brain tissue as a result of the problem with the blood flow or blood supply to that portion of the heart. So that's the stroke. And while we are in this page here, I'd like to point out that there are two different kinds of strokes. One happens when the blood vessels narrows down because of the collection of debris like atherosclerosis, blood clot, thrombosis. That will prevent the blood from going past. That's called an ischemic stroke. The other kind of stroke has to do with the rupture or the breakage of the blood vessel. The blood vessels that supply the oxygen and hemoglobin to the brain can actually rupture and break out because of various reasons, some of which we can talk about a little bit later. And this breakage of the vessel will cause hemorrhage or bleeding, and we call that as a hemorrhagic stroke. So there you have it. What's a stroke? We saw that death of the brain tissue. And what kinds of strokes are there? There are principally two strokes, two types of strokes. One is called the ischemic stroke because of the narrowing of the blood vessel, thereby impairing the flow of the blood through the blood vessels. And the other type of stroke has to do with the breakage of a blood vessel causing blood to collect among the brain tissues. So those are a few introductory words for the stroke. Some of what I just said is going to be repeated as I go further for purpose of emphasis so that you have it down well. Okay, so situation one, we already saw that. When the blood vessel, an artery supplying the blood and oxygen to the heart, gets clogged off. So this is the clog, and this clog can be very ugly. This clog could be a result of collection of cholesterol, of the platelets, other elements of the blood, so that it not only collects here, but eventually closes off the supply here when there's a plaque rupture, and then the blood, particularly the platelets, deposit and cause the thrombus to be formed. So when it's clogged up, closes off this vessel, and a part of the brain goes without blood supply for too long, then you know that the stroke has occurred or is going to happen. I'm not able to play the video on this presentation, but the video would have shown, it's a technical issue, video would have shown how the blood, blood products, white blood cells, red blood cells, platelets, they travel down and they get clotted. Second situation, again, if we had a real-time movie clip here, which I have, but I'm not able to play through this computer, you'd have seen that these blood vessels that carry the oxygen and the hemoglobin can actually break up because of different reasons. One is there may be aneurysmal formation, there could be trauma, there could be a defect, genetic defect on the walls that can actually result in breakage. But more commonly, aneurysmal formation or swelling of the vessels can cause a blood vessel to rupture and break up, giving rise to bleeding into the brain and around the brain, causing the hemorrhagic type of stroke. All right, so how do the strokes affect the people? So you ask yourself, what is it that will affect me or affect different people? Now, the effects of the stroke depends on a lot of things. It's a lot of variabilities there. Number of things can go into play. First of all, we need to ask which part of the brain and for how long the brain is affected. There are portions of the brain that are identified. You have the forebrain, you have the parietal brains, and then you have the cerebellum here. And so it depends. These parts of the brains are dedicated to certain functions of the body. Some are for thinking and thought process. Some are for bodily motion and movements. Some are for various other functions of the body. So it depends on which part of the brain the stroke happened and for how long the blood supply was cut off. And so the other thing is, how does it affect them? How quickly the stroke is treated. And we're going to come back to this over and over again. Some of the things we can't help because it's going to happen, but how quickly the stroke is treated and taken care of is the key. And that's the key take-home point for us. That the rapidity or quickness of having to attend a stroke surely results in one's life saving and the morbidities that will follow. All right? Some people who have strokes will have lasting effects. Some people will have a stroke and they are fine, because you've heard of people say, I had a stroke, but I do just fine. Whereas there are people whose bodily function and brain functions are so impaired then that they may be paralyzed, partly paralyzed, unable to speak, and all sorts of things can happen as a result of the brain stroke. So brain is one of the leading causes of death and disability in the world. I was talking to my son, Derek, who is a pathology resident in Brown University at Rhode Island, and he told me this morning, Dad, that the stroke death rate is 4th in the world. Leading above those causes, death would be cardiovascular, cancer, motor vehicle accidents, and COVID. But stroke death rates are 4th in the world in that order. Now, we spoke about this a little earlier, and this is pictorial of what I have just stated. That one kind of stroke was the ischemic stroke, when the blood vessels were clogged, they're plugged off. As a result, the portion of the brain becomes necrotic and dead, and so that's called an ischemic stroke. The hemorrhagic stroke, on the other hand, is because of the rupture or breakage of the blood vessels, resulting in collection of blood in the tissues of the brain or surrounding the brain. Okay, how can we tell if someone is having a stroke? And we have to have a little edge. You probably know this, but it's worthwhile talking about it. So now you are in a position that you are at home, or you're in a mall, or you are in a public place, and you are going to help diagnose if this is a stroke. So try to remember this word fast, F-A-S-T. And each of these letters, F, A, S, T, stands for something. And if you have this in your mind, maybe you'll be the first one to say, this person is having a stroke and we need to get him help soon. So what does it stand for, F-A-S-T? Take home point would be F-A-S-T, and sometimes it's preceded by B-E. B fast, B-E-F-A-S-T, and we'll cover this in a moment. Okay, F is very simple. F stands for face. You got to look at somebody's face, and we will be seeing a few more pictures about that. You got to look at the arms, the face, the arms, and listen to the person having a speech or trying to speak in his words, and there's some problems there. And then, of course, the face ends with time. You got to rush and get the ambulance or take somebody in a hurry to the hospital. All right, let's talk about the face. Okay, how does this patient's face look? Is it uneven, or there's a droop on one side? If you look carefully, you see that the right side of this patient's face is crooked, it's drooping. On this patient, it's not very clear, but it could be that the left side of the face may be very slightly drooped. And the real picture of this patient is very handily, you can see it's not right. One side of the face is drooping. So drooping on one side of the face, referring to the face, would be a tip-off that this patient may be having a stroke. All right, next is F. We've done the face, F, and now we have the arm, A, F-A. Look at the arms of this patient. If he's asked to hold his arms and hold them together wide in front, you're going to find that one of the arms might drift down. It's weak. He can't put them in a way that will be held together. So drifting down of an arm compared to the other side was certainly a very, very important sign of a stroke, and that we got to be thinking that this patient may have a stroke. So there you have it. You got the face, F. You got the A as the arms. And so let's move on to the next. Come to the speech. If you hear this patient say something, the patient's having trouble in speaking. His speech sounds very strange. He's talking with something that doesn't make sense. I'll just pause here for a moment and tell you a real life story. Back in Maryland, when my wife and I were in training in doing residencies, my dad lived with us. My dad was 73 years of age, and one Sabbath morning, as we were planning to go to church, my dad was not ready. He was a pastor, but he wasn't ready. He was still in his sleeping pajamas. So I came down and I said, "Dad, aren't you ready?" And he wouldn't talk back to me. On the other hand, he sat down on a table, and I saw his arms go. So there was something not right, and his thought process and his speech was not right. And even as a young resident doctor, it didn't occur to me what was going on until he picked up the phone, and then I saw that he was stumbling, and then obviously right away I knew that something was not right. So I really saw a stroke happening, and to my own loved one, my dad. So I'll never forget, about some of the things we are talking here today because it was so personal. So the speech, strange sounding words, something that doesn't make sense, or the words don't come out well, would be a great concern that may be having a stroke. All right? What about the FAST? T stands for the time. And the time is very critical, so you got to call an ambulance right away, and you need to act very fast. All right? FAST, that's the word we are trying to remember. The time is the last letter of this word here, and it stands for the hurry. You got to go sooner, because the sooner the treatment begins, the better the chances of recovery. So you got to do fast. Call the ambulance, put him in the car, take him right away to the hospital. Unfortunately, the video is not working. It was a hilarious video about monkeys acting as attendants here, but unfortunately not able to play. This would have made you laugh, and you would have had a little laughter with that. Unfortunately, can't do that. Okay, so to repeat here, I've done some of the repetitions so that we understand and we want to recall them over and over again for that purpose. Face. Does the patient's face uneven? Is there a droop on one side? A, arm. Is one arm weak or numb? Does one arm drift down if he tries to hold both arms together? Speech. Is the patient having trouble in speaking? Is the speech sound strange to you? That may be a tip-off. And finally, the time, and you got to be moving quickly when you see the signs and calling an ambulance, and you need to act fast. The time is very critical and important. All right. So we had the word fast, but we're going to add two more, like a be fast. You got to be fast. Okay. So what's a be added to the fast? So the be is a word for balance. Is the patient having trouble in standing or walking? So we add to what we already said about the fast. So the be, like a be, balance is be. If you have problem, like this patient having problem in balancing, that would be a concern that is maybe a stroke. And the E stands for the eyes. If there's a trouble having a proper vision, that may be a manifestation of a stroke also. So we learned it here. Balance, you got the eyes, the face, the arms, the speech, and the time factor that we've talked about. Again, the repetition, I've done this on purpose. Face, is there a drooping on the face? Is there a weakness on the arms? If the speech has difficulty, and time to call for an emergency taking to the hospital. All right, so how do we assess the initial, what do we do when we find somebody's having a stroke? You are in a mall, in a non-hospital situation, and you want to help out by saying, how can I do an initial assessment? And then what should be done to manage the stroke when you are the first responder on the spot? All right, so goals for the initial phase include, we got to make sure the patient who is having a stroke is able to have a breathing properly. So we need to make sure that the airways are clear. Sometimes we may do a chin or the jaw thrust or lift. And then sometimes we even have to resuscitate them by breathing into their nostrils and their mouth through the proper resuscitation equipment. And then we got to make sure that when they're having stroke, that the circulation, the pulse is maintained. If not, you have to do CPR and other procedures to maintain this patient not dying on you right away. So the initial assessment should be making sure the patient is able to breathe well and has a proper circulation. All right? So, what else can we do? Once we have attended to this patient initially and stabilized the patient, we need to find out if this patient who's having ischemic stroke is a candidate for further treatment. And there are two sets of treatment that can be delivered. The first one, patient who is having ischemic stroke, if they are candidate for intravenous thrombolytic treatment, which is another word for saying at arrival at the hospital, we can deliver thrombolysis or treatment to fight the blood clot. That's one treatment, which is the bulk of the treatment. Then the second treatment is if the patient is a candidate to have an endovascular thrombectomy. It's a big word, but basically it means if the patient is going to have an angioplasty in the brain. A picture of that is given here. Sometimes they put in a basket and get hold of the clot and to suction it out. Sometimes the clot is dismembered by inflating a balloon. So this endovascular procedures called a thrombectomy can be performed, but the thrombectomy procedure is not very common. It's only available in specialized hospitals. But the candidates for the treatment of intravascular thrombolytic treatment, thrombolytic therapy is the bulk of the treatment and have a very good outcomes in majority of instances. All right. So once the patient comes initially to the hospital, of course the code stroke is called and everyone is alerted to do their respective roles in playing to take care of the stroke patients. So immediately the labs, once the patient gets to the bay of the emergency room, then very quickly we got to do the blood tests. We got to do a finger stick to check for the glucose. We got to check their oxygen saturation, make sure the patient is not desaturating. Of course, we need to do an EKG and some other labs, we send them together. But most importantly, other than the blood works and EKG, they got to have a non-contrast brain CT, brain scan. And some places where the hospitals are equipped with a brain MRI, then that would be an alternative treatment. But to have a brain CT consisting of non-contrast study is the key test for trying to decide if this patient has an ischemic stroke from the blood clots, or is the patient is having a bleeding in the brain, hemorrhagic stroke. So those things about the CT scan or the brain MRI, very principally two main tests that needs to be done right away, other than the blood test, the glucose, oxygen, EKG, and the rest of it. All right. So I alluded to the brain imaging, and the brain imaging is done with there's a typo over here, brain CT or brain MRI, to identify if there's a hemorrhage or the extent or the degree of the brain injury, how large or small it is. And then, of course, when you look at the blood vessels in the brain, we should be able to tell if there are any vascular lesions, such as any stenosis or clotting of the vessels that are present, and some of that can be helped with the angiographic approach. All right, so here we go. To summarize what I've just covered, initially we need to make sure the patient is breathing well, the airway is clear, there's oxygenation and the pulse and the blood pressure is fine. Then the patient should be sent right away to determine if there's an acute ischemic stroke from ischemia or blood clots or thrombosis. Are they candidates for the intravenous thrombolysis, thrombolytic treatment, or are they candidates to have an endovascular thrombectomy, a procedure done percutaneously through the arterial system? All right. So immediate labs were again, to repeat, non-contrast brain CT or brain MRI, finger sticks for glucose, oxygen, EKG, other labs. Now, I'm restating this, that there neuroimaging, imaging of the brain to exclude the hemorrhage, the degree of brain injury, and to identify vascular lesions or stenosis, and to have brain CT or brain MRI. Okay, so question is, how are the strokes treated? Okay, now the treatment depends on what kind of stroke you're having. We've covered that in some ways. You need to go to the hospital very quickly, take home point, to figure this out. How can we figure this out? If you have a ischemic stroke, a hemorrhagic stroke, you need to go to the hospital. At the hospital, the test will confirm if you're having a stroke. Are you really having a stroke? Or the stroke symptoms? Sometimes we encounter patients who come with stroke-like symptoms. They may be having other problems, metabolic problems that may appear like a stroke, or sometimes there's malingering. Some people like to think that they're having stroke for various beneficial reasons. Some people who don't want to go to work, they say, I'm having a stroke. But we need to tell the difference. Are they malingering? Are this truly a stroke? There are other reasons people like to have symptoms of stroke when they're really not having stroke. So these assessments in the emergency room and the hospitals are very important. I've already spoken to you about the CT scan, MRI, and it gives you a picture of three-dimensional imaging of the brain. And then we look at the blood supply in the vessels, if there are any major areas of blockage or stenosis. All right, so how are the strokes treated? Some of which are already I alluded to earlier. So as we saw that patients who are having stroke because of a clogged artery, then when the clogged arteries are found out, they can be reopened. Those arteries can be reopened, and that can be done medically and also can be done percutaneously through an intervention from the neurosurgeon. Sometimes the medicines can help declot, and sometimes these medicines should be started so that in the future there'll be strokes that will be prevented. Some of these portions are for the medical personnel who are experts in this field, so we're not going to go into in depth about various medications and their effects and the benefits and risks there. So we'll simply say that once they get to the hospital in the right hands, they would be given the right type of treatment medically or surgically. All right, again, how the stroke's treated. On the left side, you have a scan of the brain, the CT scan, and you find that it looks normal. There are what appears to be normal findings on the brain, whereas the image on the right side, the brain tissues are infarcted, and more so, there's a necrotic or dead tissue of the brain in this part. So this is a stroked out brain affecting this portion of the brain. All right. Sometimes these patients, other than ischemic stroke, can be caused by bleeding, and with the rupture we talked about. The bleeding can happen inside the tissues of the brain, intracerebral hemorrhage. Sometimes the bleeding can happen outside the brain in the subdural spaces. So a number of things can go on to compress the brain when the brain is bleeding. Sometimes we got to stop the medications that increase the bleed. Now, we're all aware that there are some medications, particularly the anticoagulants, and some of you may already be on some of those. And the NOAC, the DOAC, the warfarin, those medications can cause increased bleeding. So once we find that the stroke has happened because of the presence of those medications, then we got to stop those medications or reduce the dose to a lower dose, depending how critical that medication is for. Then I've alluded to the fact that a surgery can be performed or a procedure that can treat the blood vessels to prevent more bleeding. And that's one of the roles of the acute care in the hospital. Now, I put what I just said again in one slide, and I did it on purpose so that I want to say it one more time, so that it's an emphasis, and then on purpose I've done this so that it is done for purpose of re-emphasizing it. Okay, how are the strokes treated? Okay, the treatment depends on what kind of stroke you're having. You need to go to the hospital very quickly, right away, to figure this out. At the hospital, you will have imaging to confirm a stroke and figure out what type of stroke it is. This involves imaging with a CT scan or cardiac or the brain MRI, which will create pictures of the brain. Other imagings can be used also, like an angiography of the brain. And we're going to find the spot or the location and to look for the blood vessels in the brain. And sometimes we check the heart also, because the basic pathology or pathophysiology about the brain stroke and heart stroke are similar in that the blood clots are formed, and usually we say there's a plaque rupture. So the mechanism, pathophysiology of the brain stroke and the heart stroke, like a heart attack, are similar in many ways. We need to find strokes that are caused by the clogged arteries. We mentioned about that. And we find the clogged arteries, we want to unclog them. These treatments can help recover from the stroke. And then we need to put them on medications to prevent new blood clots. These medications can also help prevent future strokes. Now, those patients who are bleeding and having a bleeding stroke can have treatment catered to the bleeding problems. And we can stop the medications that have actually caused the bleeding or give them at a lower dose, and be prepared to have surgery, neurosurgery, or a procedure that we can employ to stop the blood vessel from bleeding further by trying to repair them. Now, we have talked in some sense about what we are about to say here, and we are specifically going to talk about acute ischemic stroke. So the blood clot has caused the condition called acute ischemic stroke, AIS. All right? The acute ischemic stroke should be attended early. The early treatment for this has the best benefit. So bring the patient in very quickly, and we're going to make selection to see who are the appropriate patients who need to have this treatment. Is this the right patient in terms of the condition we're dealing with? There's an ischemic stroke, and we need to find out who are the candidates. So there's a selection process that goes on. So the patient comes into the hospital, is wheeled into the emergency room, and an immediate neurological evaluation is done. Face, arm examination neurologically. We talked about BFAST symptoms. So neurological evaluation is performed. Then neuroimaging we talked about by the CT scan and MRI. Then the pre-hospital emergency services consisting of ambulance that wheel the patient or bring the patients in immediately, are part of the stroke management or services. Once the patient comes to the emergency room, you have emergency room physicians who get involved and go to work, and they mobilize the interventional neuroradiologists. So they read the scans and try to decide if there's ischemic or location, the extent, if there's any bleeding involved, and so on and so forth. And of course, the neurosurgery team is always alerted to be on the standby so that if they are identified to benefit from the surgery, they would be done so. All right. Now we're coming to, again, the acute ischemic stroke, and the part 2 will tell us the things we would routinely do in the hospital. So this reperfusion therapy is called the intravenous thrombolysis, okay, IVT, intravenous thrombolysis, where this is considered to be the main step of the therapy. Heavy lifting is done by the intravenous thrombolysis. All right, so we go through a checkpoint of, are there any absolute contraindications? Did the patient have a surgery 2 weeks ago? Did he have a motor vehicle accident? Did he have a heart attack? Did he have another stroke before? Are there any risk of further bleeding? Are they prone to complications from bleeding? And if there's any wound puncture, or those kind of things would exclude the patient from having a thrombolysis, because they would bleed a lot if we actually give the thrombolysis treatment and the patient has some problem and we were not able to see that they can bleed in the brain, in the abdomen, other parts of the body. So it's very important to have a checklist to see if this is appropriate for the patient to have a thrombolysis treatment or not. So other than the thrombolysis treatment, which is a medical treatment, it's a clot buster, we are prepared to do mechanical thrombectomy, and some of that we alluded to earlier, where a simple word we can say percutaneous balloon treatment or evacuation suction can be done so long as there is a large vessel occlusion. The small vessel occlusions are not suitable for mechanical thrombectomy. So the large vessels are appropriate, and so we make the appropriate selections to see which can be treated mechanically and which can be treated with thrombolysis or medical treatment. All right. So if the patient comes within 3 hours, slam dunk. No absolute contraindication. Patient is otherwise presented very rapidly, early enough. Within 3 hours, then you give them the NT-place, which is a thrombolysis, which is an injection given through the IV. So this is the bulk of the treatment involving the intravenous thrombolysis treatment. Once we know that they are within the 3-hour window, no problem, slam dunk. We got to do this unless there is a contraindication. All right. How about if, so there's usually, why are we talking about 3 hours? Why is the patient not here within 20 minutes? Why is he not here in half an hour? That's because oftentimes the patients are not sure they're having a stroke. Sometimes it happens at night when they're sleeping. Sometimes they are in a location, let's say in the bathroom or toilet, and they saw something different, but they're not sure, they want to ignore it. They are half sure that something happened. So we've got to time it right. So patients may realize that, no, this is not right. By the time they're convinced that there is a problem, it could be a couple of hours before that can happen. So, but if we can time it right, he said, yeah, I had the CBS News at 8 o'clock, and then I felt this way, then you can go back and say, yeah, it started 8 o'clock, now it's 11 o'clock in the night. And so you can sort of go back and sort of time it in the right way. And believe me, there are sometimes patients are not sure when it happened. And there are times when you're absolutely not sure when the stroke may have started. So, but timing it right is very important. But if they are within the 3-hour period, then the the alteplase thrombolytic treatment is the appropriate treatment. Within 3 and 4.5 hours, again, this thrombolysis treatment is appropriate. But when it goes beyond 4 hours, 4 to 6 hours, then we cannot give routinely the intravenous thrombolysis treatment because the brain may have already infarcted, or giving so may cause more bleeding. So once you go past 4.5 hours, 6-hour period, then the IVT, intravenous thrombolysis, is not appropriate. Now, very sure that beyond 24 hours, it started yesterday, but I didn't feel like going to the hospital, and it happened more than 24 hours, then they are not eligible for thrombolysis treatment, and they are not even eligible for mechanical thrombotic treatment. So the time frame is very important. Beyond 24 hours, you know the damage is done, and then you have to stabilize the patient, and you can't really change the course at this time. It's too late. So the time frame is very important. Absolutely important to do it within 3 hours. 3 to 4 hours can be done, with relatively many hospitals still do it. Beyond 4.5 hours to 6 hours is not routinely done for the thrombolysis, and beyond 4 hours, we would say sorry, but it's a little too late. All right, now we're coming to the bread and butter about prevention. Can strokes be prevented? This is why all of us are here now. We want to know, can it be prevented? What should we do to prevent it? And some of the things that we need to go over and over again. Nothing I will say here in prevention is not known to you. You know it all. But we'll do that anyway for the purpose of emphasis and for you to sort of rethink about it, and hopefully it might come handy in a situation that you are in. So, can it be prevented? Yes, many strokes can be prevented. That's the answer, okay? Though not all of the strokes can be prevented. Some of the strokes are somewhat genetically predisposed. When they have thin blood vessels, they have aneurysms, they have AV malformations of different kinds, that cannot really be prevented, but those are rather small in number. Now, you can generally lower your chance of having a stroke, and how so? All right? Part one, the taking your medicines exactly as directed by the physician is very important. Taking your current medications that you're on are especially important in preventing strokes. So what are those medications? So the blood pressure medicines are very important for you to be taking so that you keep your blood pressure under control. Now, we need to have your cholesterol lowered, and we use the medicines called statin, the atorvastatin, pravastatin, and all sorts of statin medications can be useful. So keeping the cholesterol down. So blood pressure medicines, the cholesterol medications, the statins, all right? Those of us who are on medications for the blood thinners, like an aspirin, or blood thinners, like warfarin, NOAC, DOAC, those one can prevent the blood clot. So you got to be taking these medications that you are already on. Okay? Then what about controlling the blood sugar? You need to keep that as normal as possible for those who are being treated for diabetes. So there you have it. Blood pressure, the cholesterol, the blood thinners, aspirin and others, and then of course the diabetes control. So doing this will prevent a stroke in a large number of us. So it's very important that we continue taking the pills that you're already on as directed, as was determined to be appropriate. All right. Part two of preventing the stroke. All right. we need to make lifestyle changes. We need to do things differently from what we have been doing, or if we have not been doing, then the right things to do is that. Those who smoke, and this talk is not for the Seventh-day Adventists, but this talk is for everyone outside. Those who are smoking, you got to stop smoking, and that'll prevent the stroke to a lot of time. You got to get regular exercises. Be out there. Do the physical exercise. Walk for 20 minutes, 30 minutes, 5 times a week, so that your muscles are toned and you prevent the risk of having a stroke. So not only stop smoking, which is common sense for everyone, you got to do the exercise. Those who are sedentary, couch potatoes, you got to get up and find that time so that you go and do a leisure, casual walk. If there is another time, we can talk how the exercise should be done and how we should raise our heart rate. That will be the most beneficial. But in short, if you're out there exercising and just walking, walk, jog, little walk, 20 minutes to 30 minutes a day, 5 times a week, would be greatly beneficial to have the stroke problems reduced. Lose weight, those who are overweight. I find that majority of us here are not really overweight. Some are not obese, but some can lose a few pounds. But losing weight, if we are overweight, is a good thing to do. Now, what about diet? Okay, the Seventh-day Adventist diet, what Sister White told us, still stands true, and we knew about this over 100 years ago. So what it is? Rich in fruits, vegetables, low-fat dairy products. Those who eat meat should eat low or small amounts. We do not recommend sweets in large amounts and quantities. Refined grains are not good. But in general, we have a health message that's very attuned to having a good health. Fruits, vegetables, low-fat dairy products, and those who eat meat, smaller amounts, and lean meats would be the thing to go to. Eat less sodium. Don't go and shake that salt shaker beyond what you should. Okay? Now, talking about alcohol, we certainly don't drink, but those who do may want to limit it. If you are a woman, 1 drink a day, and if you're a man, no more than 2 drinks a day is what is recommended for general health and for prevention of stroke. This is a part 3 of the prevention of stroke. Can strokes be prevented? And this is a part 3 I'm talking about here now. Another way to prevent stroke is to have a surgery or procedure to open a clogged arteries in the neck. So in the neck, we have the carotid arteries. And if you do an ultrasound or CT scan of the carotid arteries, we find there is a blockage of, let's say, 80%, 90% of the blockage. Then we need to remove the neck blockage, because the neck blockage can cause stroke in the future. So doing carotid end arterectomy surgery or intervention by angioplasty or stenting in the neck is a good thing to have this prevented, the stroke prevention. So routinely, if a patient comes with a stroke, we do check the necks to see if the carotid arteries are clogged, and if they are, then electively we want to perform a surgery called carotid end arterectomy to take care of that. And sometimes, instead of the surgery, we can actually put in a balloon and a stent to do an angioplasty of the neck. This type of procedures that I just talked to you about is in a small number of patients and only in the appropriate setting. All right, again, summarizing the prevention, how we can prevent that in short is this slide, okay? We talked about this again, but this is pictorial way of looking at it. All right, keep your blood pressure low, under control. Less than 130/80 should be the goal and less. Keep your cholesterol well controlled. The LDL level should be less than 70. These numbers you don't remember, then this is for the doctors to remember. Eat healthy food, we talked about that. Low fat diet, healthy diet, fruits and vegetables, all right? We talked about doing regular exercise. We emphasize that, and we should all try to do this. Now, I come across people, including myself, feeling bad if there are times when I don't have time to do it, and we missed out in doing so for different reasons, work-related. Sometimes we are sick, sometimes we just don't feel like it. If you skip a day or two or three, do not dishearten, but you can pick up another time. Yeah, I missed out 1 week, was traveling, but then come back and do that when you can and establish that routine. If you do something routinely for 2 to 3 weeks, then it becomes a habit and it becomes a part of life. You're mentally and emotionally forced to do it because it's a habit now. You can't do without it. So try to make a habit out of it. Treat sleep apnea. Sleep apnea of late has become an important issue for one's health. Sleep apnea can cause hypertension, pulmonary hypertension, can cause atherosclerotic heart disease, heart attack, and many other bad things can go wrong. And it can also cause stroke. So sleeping well at night, have a good sleep physiology, and sleeping with a sleep apnea treatment with a CPAP is very important. So if you snore at night and your spouse or your friend tells you that, you were snoring last night, better have that checked out by having a sleep study. Tell your primary doctor to order a sleep study so they can find out if there's an obstruction or snoring that will require you to be sleeping with a sleep apnea with a CPAP. So that's something that you should always talk to your primary doctors to help you out with that. But sleeping with a CPAP is a very good thing to do for good health, and also will help you prevent the stroke. In this talk, we were talking about stroke. Managing your diabetes, keeping your hemoglobin A1C level less than 7, okay, and drink in moderation, or don't drink at all. Not drinking was the best thing, but those who do should do so in moderation. Common sense would tell you to stop smoking. Do not go to secondhand smoking places that will clog out your arteries, okay? Avoid stress. Sometimes we need to find some ways to avoid stress as much as possible. But obviously life is full of stresses and we just have to deal with that. But when we can avoid stresses, do that. It helps in preventing stroke. Then to maintain a healthy weight. All right. Now we go to a different topic about TIA. You've heard that? What is a TIA? TIA, but it stands for transient ischemic attack. Okay? So this is like a small mini stroke. It's not a full stroke, but it's like a mini stroke. So it's a transient or very brief attack on the brain, which is like a stroke, but it does not damage the brain. So you could have a TIA, a stroke-like event, without suffering a damage to the brain. So does that mean that this is a good thing to have a stroke or a TIA? All right, not necessarily, because it's also a serious condition. Okay, TIAs can happen when the artery in the brain gets clogged momentarily, or closes off for a short while and then reopens on its own. Why does this happen? Because the clot which was formed can thrombolize spontaneously, breaks apart sometimes, and the blood flow is maintained spontaneously. So yeah, you're going to have a stroke. It started off like a stroke, but the clot broke off and disintegrated, causing just a TIA without resulting in a brain death or a brain infarction. All right? So this happens because of the clot formation that moves away or dissolves on its own. Okay, even though the TIs do not cause lasting symptoms, they are very serious. If you have a TIA, you are at a high risk of having a stroke. It's important to see your doctor and take steps to prevent that from happening. Do not ignore the symptoms of a stroke, even if they go away. So if you had a stroke-like symptoms, they're gone, and you feel just fine, do not ignore it. You got to follow up and make sure that it doesn't happen again, or something worse will not happen. So that's the TIA, a serious condition, but momentarily it seems like everything looks fine, but it's not truly to be ignored. In a pictorial way, blocked blood vessel causes stroke. In the carotid arteries in the neck, blockage in the internal carotid artery, something that we talked about, having surgery or angioplasty, percutaneous intervention, stents. Then this is a pictorial of a blood clot in the middle cerebral artery, showing the deposits of cholesterol, the calcium, the platelets, the thrombin, and all the rest of the cascade of the coagulation. Now, what if you had a stroke, already a stroke? We're coming towards the end of this presentation, and we're going to talk very briefly in the next few slides about this secondary prevention. We use the word secondary because the primary event of stroke has already happened now. Now you stuck with had a stroke, what must you do to prevent from having another stroke or TIA? So now one is in a wheelchair or in a nursing home, or maybe at home with limited physical abilities. So we need to, how can we prevent a secondary prevention? Now, we don't want to have more stroke. We have had enough. So secondarily, what should we do? Okay? So the stroke patients are at risk to have decreased mobility. We all know about that. Can't walk well, using a wheelchair. And sometimes limitations are variable at different levels. So what we recommend as patients who already had a stroke to have exercises. And many times these exercises can be supervised, like going to a rehab where the proper exercises can be performed. You got the stroke now, what should we do to prevent it? Exercise and supervised exercise like in rehab. Very important. Then the secondary prevention for stroke, we don't want to have more stroke. You got to make sure that you do not have atrial fibrillation. Now, atrial fibrillation is a cardiac condition where the rhythm of the heart changes from regular sinus rhythm to atrial fibrillation, where there's irregular heartbeats. They are prone to causing stroke because the blood clots are formed. So those who have had a stroke, we got to look out and say, hey, you don't have atrial fibrillation, because if you do, then we got to treat this atrial fibrillation so that you do not have a second stroke. So it's very important for us to be sure that we are not having atrial fibrillation. So it's the work. Nowadays we all have smart watches and iPhones and other type of devices where you could actually look at your rhythm and see, is it regular or not? Sometimes if the irregular rhythm comes on, it's irregularly irregular, then you need to bring it to the attention of the doctor so that if we make a diagnosis of atrial fibrillation, then you got to treat that so that the stroke can be prevented. So it's very important, those who have had a stroke, we don't want further stroke, then we got to have the atrial fibrillation taken care of. Or put them on long-term monitoring to check for the atrial fibrillation. In the long-term monitoring, there are different ways to do that. We can place somebody on a Holter monitor or event monitor, and sometimes we can place devices under the skin for monitoring also. There are different ways to check that, but if you got a stroke, you don't want to have another stroke, you got to look for atrial fibrillation, make sure we're not missing it, because if we miss it, then it's a shame that one stroke will lead to another, and then next thing is sort of end of life type of situation. The last item here is called a PFO closure. PFO stands for patent foramen ovale. This is a little hole in the heart. It's present between the right atrium and left atrium, so the blood can flow from the left atrium to the right atrium normally, but sometimes when there's a reversal of the flow because of the PFO, a hole in the heart, then it can cause stroke. So we got to look for the PFOs and close them. If you had a stroke, we got to be looking for a PFO to close it. We got to be looking for the atrial fibrillation that you don't have further strokes or more clots. So these are some of the things we can do as a secondary prevention, those who already have had a stroke before. All right, summarizing this, the secondary prevention after a stroke or TIA, you got to be on antiplatelet therapy. You want to have treatment given so the platelets don't attach to each other and do not clot. So they got to be on an aspirin. Sometimes we place them in a clopidogrel, we also call Coreg. Some of you probably familiar with that. And sometimes we put them in combination of aspirin and clopidogrel. We call them dual antiplatelet treatment, a therapy called DAPT, D-A-P-T. So aspirin, clopidogrel, a combination of aspirin and clopidogrel is a treatment to prevent secondary prevention once you've already had a stroke. Now, and the anticoagulation like warfarin, DOAC, NOAC are not routinely indicated, except in some special cases and of having AFib or DVT or pulmonary embolism, then you need to be an anticoagulant there. If you are on anticoagulation already before you had a stroke, then we're going to stop that for 2 to 4 weeks so the brain can heal and we put them back on that. Then I already alluded to that the PFO, the hole in the heart, the hole between the right atrium and left atrium, the upper two chambers of the heart, needs to be closed so that we can take care of the paradoxical embolism that will cause further stroking of, and we want to prevent that from happening. Okay, secondary prevention for the stroke and TIA, and the risk factor management we talked about basically blood pressure. Again, coming to that, less than 130/80. LDL, low density lipoprotein cholesterol, less than 70. And you got to be on a high intensity statin, like atorvastatin or high simvastatin. Or if you are diabetic, type 2 diabetes mellitus, make sure your hemoglobin is less than 7%. Hemoglobin A1C is less than 7%. The diet, the Mediterranean diet, I would say Adventist diet, and sodium restriction, smoking cessation, eliminate or reduce alcohol, weight loss if you're obese or overweight, and treat obstructive sleep apnea, which we already alluded to. So with this, I want to thank you. And if there's any questions, there may be a mic to pass around. I'll be happy to answer any questions you may have.
Doctor?
Yes.
I'm not saying. I have a question.
Sure.
Every time I go to the doctor, they said my heartbeat is slow, and they ask me, and then I'm under observation with the device, and they ask me to eat a lot of salt. So can you explain, what's the difference? I mean, is that bad for the heart? But it turned out okay. But every time I go to the doctor, they always say it's like 40 to 80, and they always ask me, stay here. We'll have to get the blood pressure again and everything. But they ask me to take more salt.
More salt? Okay. So in order to answer that question, I need to know a little more information. My experience, I'll share with you. But without knowing all the details, I cannot give you an official opinion because many things goes into making those kind of recommendations. But the common things are, if you are dehydrated and you have volume depletion, you need to avoid salt. Whereas if you are overhydrated and the volume is increased, then you want to restrict the salt intake. It depends on your blood sodium levels. If the salt sodium level is low, like 125 or 130, then we would recommend that you be on salt, extra salt. Or sometimes when you are passing out, you have lightheadedness, you are dizzy, and as a result, we think that you have orthostatic hypotension because your blood pressure comes down more than other times, then that will be another reason for you to be in extra salt. But these recommendations of low salt is for general diet on patients who otherwise have normal salt levels. So I don't want to be very specific about recommendations, but in general, some of those are common things to think about. Okay, sure. Okay.
Can you hear me? Okay, I wanted to find out how often do the physicians check for after you've had a stroke and they have you on all these medications? How often should they check, and how do they check to see if the warfarin's causing a brain bleed that you talked about?
I'm not sure if I caught the question, but I understood that you want to know which medicines will cause brain bleed. Is that what it's saying?
Yes, and how often after you've had a stroke do they check you?
Oh, yeah. So when one has a stroke, we actually check everything. What medications you are on, what medications have the potential to cause the bleed, what medicines are underutilized so they may cause blood clots. So we look at every medications, but in reality, the effects of medications causing strokes are not common. The general stroke situation where people are seen in the mall, on the playground, or watching TV, those are different set of patients who are not necessarily medicated to have those strokes happening. These strokes are spontaneous strokes. These are strokes that happen because of blood clots and blood rupture, which have generally not connected to medications. Although I have to say that there are medications that can cause stroke, particularly if you are on warfarin or Coumadin, patients who are on Eliquis, rivaroxaban.
Yeah, he's on warfarin, and they have him come in every 2 weeks or something to check.
So make sure that warfarin, those who are taking a warfarin, their INR levels are always under control. Generally, it should be less than 2 or 2.5 or 2, and that will cause you not to have a stroke. So the warfarin is particularly important to cause not a stroke, to have the INR level always checked and kept under that level that has been recommended for you. Okay. Does that answer your question? Okay. Yes.
Hi, doctor. Good afternoon.
Good afternoon.
Okay, so I have type 2 diabetes, and my doctor, one of the two of the medications he gave me is low-dose aspirin, 81 mg, and my statin is simvastatin. But here's the thing. For the simvastatin, he recommends I take that at night because it may make me drowsy. According to him, it has a drowsy sort of effect component, and the aspirin I can take in the morning or sometime in the day. But for me, for my body, it works. It's working in me the opposite. The aspirin is the one that makes me sleep. It acts on my body like a sleeping pill, like I'm out 5-10 minutes after. So I really have to take that at night. I can't take that in the daytime because I drive around. And then the simvastatin, that's the one he recommends for night dosage, is the one that doesn't make me sleep. I'm wide awake, I go anywhere. So I thought I had to do the reverse in the time I take which one and which one. How, I mean, is that
Yeah.
really, is that just my body's, how my body manages it, or
All right.
is that something you have seen before?
So I have a comment about aspirin. Generally, aspirins are not recommended in general, except if you had a stroke, if you had a coronary artery disease or heart attack, or peripheral vascular disease. So those are the conditions, situations, and if you are between 40 years and 70 years of age, then aspirin may be given, but in general, we have moved away from aspirin as a primary prevention treatment. So if you are taking aspirin for no real reason, then it's best not to take one because it's not going to be helpful. There are very limited number of well-established reasons to take aspirin, and it does not meet what you just told me. Seems like it's not needed for you.
So just to respond to what you're saying, I'm over 40. I'm between 40. I'm not 70, but I'm over 40. So
Right.
I'm.
But still, if you do not have any of these comorbidities, like I just mentioned, stroke, or heart attack, DVT, then an aspirin for primary prevention is still not a first-line recommendation because the benefits will outweigh the risk of bleeding from the aspirin. So my hunch is, not knowing everything about you, and I cannot give you specific recommendations from the pulpit. I need to review your chart, and for an official opinion, that will be a different setting, not on a talk like this for a specific recommendation. But it just seems like aspirin is not needed for you. As to the simvastatin, nightly use is the best one because it absorbs in the liver and there's the metabolism and is well tolerated, and usually it should not be associated with feeling dizzy and all those kind of things. Usually not the case. Okay, and you had a question? Yeah.
How does it occur in PFO?
The
The
PFO.
question is about the PFO and the hole in the heart, and how does it occur, and who gets it, and then if you have one, what to do about it?
Okay, I'm glad you asked that question. So PFO again stands for patent foramen ovale, which is a congenital condition where one is born with. The PFO is present from birth. All of us had PFOs to start with, but as we get older, only about 25% of us, 25-30% will have PFO, but it's usually in a dormant state. It's very quiet. So rarely, some of the PFOs will show up as a stroke because of the paradoxical embolism. So yes, you're born with the PFO. It does not happen during life. This is something, the PFOs close at birth, and then about 25% of us have PFOs, and rarely few of us will have stroke as a result of that. But if you've had the PFO found out on transesophageal echo or echo, and you had a stroke, then we need to close that. We need to have that closed off with it. Okay, so before you used to do surgery, open heart surgery, so we could put a patch on the PFOs, but now over 90% of times, we're able to close it with a device. We go through the groin, work up percutaneous approach, puncture the septal, intraatrial septum, go to the left side, and then we put a device called Amplatzer device, which is a clamshell. It is like it closes off the hole and remains there permanently. It's not an open heart surgery, it's just a procedural device for us. You're welcome. Okay.
Doctor, I have a general
Sure.
question regarding stress.
Stress, yeah.
When you get older, you don't want to have stress because you might have a heart attack or something like that. When you're younger, we always have stress, right? So when you get older, you tell them, don't give me stress. I might have a heart attack. It is not possible. The older you have, it's really bad for you that you might have, stroke because of the stress. Then when you're, does it make any difference with your age?
I personally don't know the real answer, but stress in general is not good. I have to say that my wife gives me a lot of stress.
Sorry.
Just joking.
Joking.
I'm just pulling her legs. She helps me a lot for everything. Stress is a part of life. Sometimes we can't do much about it, but try to make ways that will bring pleasure to you. If you play the piano, play it. If you want to go for a walk, wants to watch a TV maybe, do something, go for a vacation, take a break. So it's just a general things to say. Now, stress is not really quantified about the stroke or the heart attack, but people generally, we see this problem of stress and a heart attack on patients who are more stressed. So we see a correlation, but it's very hard to quantitate that. But it's because we can't quantitate it, you just do something that brings more pleasure to you or brings less stress reduction is the right thing to do. Maybe sleep longer.
I just wanted to add to the stress. When you are, since I'm a pediatrician and teach, so when you are a young person, your arteries are much cleaner, okay? So you don't have that cholesterol plaque. So you can have stress and you can commit suicide. That's a different thing. But your arteries are much cleaner and much more resistant to, more elasticity is much better.
The pliance.
But as you become older, things they change. So the same stress may not affect in childhood and adolescence, teenager or young adult, but same stress can be detrimental to you when you are older.
Okay. Let me add one more thing, that while the stress cannot be quantified, but the effects on the heart and brain is very real. There is a condition in the heart. Have any of you heard something called Takotsubo cardiomyopathy? You have heard that? You had it? Yeah, okay. You know that can be done by stress. Extreme stress, death in the family, bereavement, emotional stress, financial stress, social stress. Any number of things can do that, where your heart can actually dysfunction. If you have an ejection fraction of 65% and you have this Takotsubo cardiomyopathy, stress related, you can land up in the hospital like a heart attack. You will have an angiogram, you can have stuff like that. So stress plays very important role in causing heart conditions and a stroke. So sometimes we have no control on the bereavement, for example, mother passing away or some special circumstance in one's life. But stress is very quantitated in the heart and in the brain. So doing something pleasurable and try to reduce the stress in different ways. All of us are different in reducing stress. So do something that reduces what would be a stressful situation would be very beneficial to reduce the stress. Because I think when our journey in this life is over, we probably have no more stress. That'll be the best. But while we are still here in our journey, we have to do the best we can to try to reduce our own circumstances of reducing the stress, which applies differently to different of us differently. For me, because I'm stressed out when I'm work for many, many hours together, there'll be one way to say I need to slow down a little. Okay, I need to spend more time doing something more pleasurable. For others, it'll be different. Some maybe financial, can be social, can be everything. So the stress is there, has a bad results on the heart. The adrenaline symptoms in the heart system can be revved up because of the stress. So relying on God's word that He will give us victory over things, and asking, Lord, I want you to help me so that I'll have less stress. What should I do? Should I read my Bible more? Maybe I spend more meditation or prayer. These are some of the things that would be beneficial to have a beneficial effect.
Hello. For those of us that spend every week in an airplane, you hear about strokes being related to flying and that we should get up every so often. Can you talk a little bit more about that? What are our risks?
Yes.
Is it 3 hours in the seat, 2 hours? When are we
All right.
jeopardizing things?
So here's the reality. When somebody is in a closed situation where sitting in a chair and not being able to move around, what happens is the blood circulation slows down. And particular areas of concern would be the lower extremities, the legs, the calf muscles, or that causes to have something called deep vein thrombosis, DVT. And the DVT, when it is formed because we're sitting in the airplane going to Hawaii, flying for 6 hours, and then, by the way, you know that people flying to Hawaii or long distances have more strokes than others. That's because you are sitting in a position where there's a less mobility or movement of the blood through the system, can cause clots forming in the legs. And when the clots form in the leg, next thing you know, it travels. From the leg, it goes to your right side of the heart, to the lungs, and sometimes it can cross over to the left side of the heart and cause a stroke, the paradoxical embolisms. So yes, so what we recommend is that you be aware that you got to be moving. So even when you are sitting on these long flights, you got to get up and move around, stretch, or even when you're seated, you got to do moving your arms and legs, and you look like people will look at you strangely, but hey, it'll save your life. Might save your life. So yes, so those long flights are troublesome. There's no one recommendation that I know of, but just trying to be more mobile and active, stretching out, and give yourself every half an hour, 1 hour to actually get up from your seat, move around, get your legs moving would be very beneficial to do that. Okay, I think
About the COVID vaccine. Strokes and heart attack after the COVID vaccine.
okay, so I'm not qualified for a comment on the COVID vaccine and stroke. I don't have data to say that. My own belief is that it's very rare, and that those are rather exception than rule, but I don't have data to give you any more information on that.
Thank you.
But it should be very rare, and I still encourage the vaccines to be given regardless of the concern for stroke, which should be very rare. Your benefits outweigh the risks, and so you should take the vaccine and not worry about the stroke.
There are studies being done right now, but there's no result yet, so we'll see.
Your benefits are way higher taking the vaccine than the risk of stroke. Can the stroke happen? I guess anything is possible, but it's so rare and not clinically relevant as far as I'm concerned. I don't have a data to give you official data to tell you exactly.
Well,
more.
the researchers have shown that actually the COVID infection can cause blood clotting, and you can cause heart problems and also the stroke, not the vaccine, okay? So that's what we have to understand, and actually it has also shown problems in the young adults also. So actually the COVID vaccine is much safer than COVID infection.
Try to prevent the infection from happening. That's much better prevention than the concern about the vaccine causing stroke. I think that's basically. All right. Well, if there are no further questions, then I thank you for your time, and I appreciate you listening.
Thank you, Dr. Norangi. It was a very informative and educational presentation for all of us. And from now on, we walk out of here confident that we'll try to prevent stroke as much as we can. After this, we have some refreshment back in the foyer, and I would like to invite all of you to go join us in the back and maybe have a continued talk with the doctor and his wife. Thank you.